Hello, everyone, and welcome to this Recovery to Practice webinar. I am delighted, this is Lori Curtis, and I am delighted to be your host today. Today we are focusing on hospital diversion and recovery and alternatives in recovery response. And after some short housekeeping and a short overview of Recovery to Practice, we'll begin today's presentation. On behalf of Substance Abuse and Mental Health Services Administration, or SAMHSA, and the Recovery to Practice team, we'd like to welcome you all and to thank you for joining us today. At this very moment, we have over 250 participants signing on today, and we expect that that number will grow as we get going. I'd also like to thank our presenters today, Lisa St. George and Dr. Karen Cheney, for sharing their knowledge and experience with us today, and we'll introduce them in just a moment. At the end of the session, you'll be able to download a certificate of attendance that you can use to apply for continuing education credits for your professional association. And we've got some good news. The webinar has been pre-approved for continuing education from NADAC, the Addiction Professionals Association. To qualify for these continuing education hours, you must attend the full webinar, complete a brief quiz, and a webinar evaluation. There'll be more information on this at the end of the webinar. At the completion of our webinar today, an opportunity to provide feedback will automatically open on your screen. So please take a few moments to let us know what you thought of today's webinar and provide us with feedback. We value it a great deal. Finally, if you have registered for the webinar, you'll be emailed a link to view the archived recording. This link will also be available on the Recovery to Practice website, where you will find links to past Recovery to Practice webinars. This webinar series is hosted by SAMHSA's Recovery to Practice. The overarching goal of this initiative is to improve the knowledge and the ability of the behavioral health workforce to use recovery-oriented practices every day. But what do we mean by recovery-oriented practices? In 2011, SAMHSA released a working definition of recovery and a set of guiding principles that incorporate aspects of recovery from both substance use and mental health conditions. SAMHSA's working definition of recovery in behavioral health is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The 10 principles of recovery shown on this slide, along with 4 major dimensions of recovery, home, health, purpose, and community, form a solid foundation for developing recovery-oriented lives and for building recovery-oriented services and systems that are necessary to support them. SAMHSA's Recovery to Practice initiative helps you turn these principles into workforce practices. Recovery to Practice offers a set of discipline-based curricula to promote the understanding and uptake of recovery principles and practices, developed by these 6 professional disciplines for educating their membership about recovery and behavioral health. These materials are available and adaptable for use by other disciplines and organizations seeking to build a recovery-oriented workforce. Links to these curricula can be found at SAMHSA's Recovery RTP, or Recovery to Practice website. And you'll see on the bottom of each slide the link to that website. Recovery to Practice is expanding its discipline focus to embrace multidisciplinary services in integrated settings. Those of us who work in behavioral health or integrated health care organizations have opportunities every day to promote wellness and recovery with the people that we serve. We can powerfully communicate hope for recovery and the value of self-care and wellness just in how we approach our work. Recovery to Practice can help you strengthen your recovery-oriented practice through free webinars, newsletters, training, and technical assistance opportunities. Many of us recognize that with crisis comes opportunity for growth. All too often, however, individuals and their families who face a mental health crisis experience fear, disempowerment, and even trauma. Today's presentation is the last of a 3-part series that examines a number of ways to integrate recovery-oriented approaches into response and support support services to help individuals in these crucial periods. I'd like to introduce our speakers for today. Lisa St. George is the Director of Recovery Practices at RI International and the Director of RI Consulting. With over 30 years of work experience, social work experience, Lisa is an expert in developing recovery-focused systems and strong peer support workforces that provide mental health, addiction, and integrated care. She has provided leadership and startup of many recovery programs in Arizona, California, and New Zealand, helping to transform systems of care to have a strong recovery focus and vision while working within existing processes and procedures. Wherever she goes, Lisa brings unending belief in the inherent courage, wisdom, and strength of people in recovery. Over the years, Ms. St. George has authored multiple books, articles, and training with a recovery focus. As a person with lived experience of recovery, she brings a unique blend of expertise to her work. Dr. Karen Cheney is the Executive Director of Consulting Services and Chief Medical Officer for RI International. Previously, Dr. Cheney served as the Chief Medical Officer for Taros Behavioral Health, where she supervised medical providers and managed clinical programs. From 2011 to 2013, she served as Medical Director for Magellan Health Services in Arizona. Additional previous experience includes serving as Medical Director at Taros Behavioral Health, Staff Psychiatrist and Area Medical Director for Value Options, and as a Consulting Psychiatrist for Chandler, Hope, and Sundance Holistic Treatment Center. In her current role, Dr. Cheney is deepening the organization's existing roots in peer and recovery training while overseeing expansion of key areas including zero suicide, next generation crisis systems, integrated care, and behavioral health leadership. And with that, I will turn it over to our presenters. Please join me in welcoming Dr. Cheney and Lisa St. George.
Thank you so much, Lori. And hello, hi Lisa, and hello to everyone who is on this webinar. What you will be seeing, can we get to the next slide, please? What you will be seeing here is a tour. We'll start a tour of our Recovery Response Center, and I will discuss with you what the vision is and how this works and why it meets the Recovery to Practice initiative. We also, in reviewing this, I realized that we are using the 10 guiding principles of SAMHSA. So let's talk a little bit about this particular RRC. This is our Peoria, Arizona RRC, and as you can see, it is quite lovely, and we are very proud of it. And as we talk, I will show you more of the RRC. Next, please. We not only have this site in Arizona, but we have other sites all over. The Peoria, Arizona is our flagship. We are opening an RRC in Wilmington. We have one in Ellendale, Delaware. We have two in Durham and Henderson, North Carolina, Riverside and Palm Springs, California, Fife and Lakewood, Washington. We also have a freestanding living room, which we will discuss later, in New Zealand, in the city of Tupuaki, and I hope I said that right. Next, please. So we are a different kind of crisis center, and why we are is because recovery is first and foremost for us there. We make use of a step-down type of program, and it kind of sounds strange, but actually it reduces hospitalization, and it allows folks to come into our program and not be hospitalized. We have a very high level of peer support providers, and you will hear this throughout this talk about our peer support throughout our system. We also help folks get just-in-time medication. This means that if they are running out of medication and they haven't seen their doctor and they don't have an appointment for a few days, we will bridge their medications after an assessment and discussion with their medical provider as well as their team. And we also recognize that social connectedness is a part of wellness and recovery, and this is part of what we instill as folks are coming in and being discharged. And our peer support coaches do this quite well. Next. We use an interdisciplinary team. We know that people in crisis need effective care and that they need folks to support them. With that in mind, we know that every member of the team is important and has a voice. That includes our peer support folks, our medical providers, our nursing technical assistants, and we also know that medication helps, but it is most effective with a dose of kindness and hope. And what we do here is, in this interdisciplinary team, is we let them know that recovery is possible. Our peer support coaches let them know that on a daily and hourly basis if necessary. Next. Okay, right now we have a poll, and we would like you to participate in this. The question is what barriers exist in your service system in accessing medication? And if you would just fill this out, and we'll take a look at it in just a few minutes. Next. Okay, so now we start the tour of the RRC, or Recovery Response Center. This is our lobby, and as you can see, it is quite lovely. We welcome walk-ins. We also have a peer support provided right as a person walks in so that they can be assisting anyone who is coming in for assessment. We have 24/7 availability for assessment and assistance, and we help with the refills and the prescriptions, as I spoke about that before. We do this because we are trying to avert a crisis and a relapse, as well as decrease the ED visits. So we are helping them get their medications in the moment with the consent of their outpatient providers. We make sure also that if they need to be admitted after their assessment, we do that, but they don't have to be admitted from the lobby into the rest of the program. Let's look at that poll, and it looks like the barrier that is really quite high at 63.2, and it's a long wait time to see a prescriber. And I think that does not surprise me, and this is one reason why in the lobby we also do those refills so that we can make sure that people have their medications.
Yeah, this is exactly what I've heard from lots of people that we've served over the years, and so, you know, it's very consistent with what we know and understand.
Right. And again, as folks come into the lobby, we really do listen to what they need, and we try to do that throughout their stay or just in the lobby. Next slide, please. Okay, from the lobby, we go to the retreat. This is an observation unit. The length of stay can be up to about 24 hours, and our length of stay average is 22 hours. It is a secure area for evaluation and for stabilization of the folks that come in. There are individual rooms and communal areas, so the person who comes in and may be agitated may want to be in an individual room and just stay calm. Others want to be part of the milieu and can be in the communal area. We serve snacks during this time, and peer support plays an important role. Again, you are going to hear me say that throughout this talk because peer support is something that we rely on quite a bit. It's important to also know that we have about 25 recliners where folks can be seated comfortably, or they can even sleep in them. We also have a police entrance where there is a nurse and a peer support that are there when folks come in, and they help to calm individuals and also educate them about their admission. Next.
And it's just important to note that right at the entry into even in the police entrance, a peer support is present to offer their support and help people understand where they are and relate to them about the experience of being there so that people can feel safe.
Great. Thank you, Lisa. Our next stop is the living room. So if someone is in the retreat or has been petitioned or has more need of having more time at our facility, they will go into the living room. And it is a warm and welcoming environment. It uses healing spaces, and let me tell you what that means. Basically, as you can see, it is bright, it's beautiful, it's calm, it's open, and there are beautiful, soothing colors. And so the environment just speaks of their being calm and working in their treatment. The length of stay can be up to 5 days. However, our average is about 2.4 days. The living room, again, is staffed by peer support workers. Again, a very important part of the treatment for these folks. Also, we have about 16 beds for those people who are in the living room. Next.
I should note that that individuals that stay in the living room have a room with a bathroom connected to it, and there are typically one person, sometimes two in the room, but most of the time one person, and it just helps for their sleep and their well-being and their comfort. Right.
It is a very accommodating environment for folks who are having a crisis. The next stop is our Peerrun Respite. Now, when I say this is peer-run, I mean completely peer-run. It is a step down from the living room, or folks can just let them bring themselves to the respite, and they can be there for a little while. What happens is that sometimes in the process of discharge, we are working on community resources as well as housing, etc. When this is going on, the peer coaches assist them in doing many of these things, but they may not have them ready at this time. So basically, they go to the respite. They can stay for about 30 days, and we're kind of flexible on that, the number of days. We have about 10 beds, and basically the peers are mentoring all the time through groups and one-on-one meetings. We also need to understand that folks are there and they can leave to go to a job, they can leave to go to appointments, and then return that day. So we have peers throughout our observation, our inpatient, and now our peer-run respite, which is obviously outpatient. Next. More about our Recovery Response Center. Our team members who are identified as peer support roles work alongside team members who may or may not have lived experience of recovery. Basically, we have peer coaches working with the teams, and there may be other peers on the teams, but we really don't ever know. And basically, they have been trained to help with the team and also help the individual. It's also important to know that there are nurses and physicians and other staff that may have a personal experience with living with a mental health concern and are in recovery. And we look at that as being, this is part of recovery, is getting back into the workforce. We also have a career ladder for all team members, including our peer coaches. Next, please. Okay. What are our team contributions? Well, everyone has a contribution to make to the well-being of individuals that we serve. All team members provide warmth and kindness and belief in individuals' ability to recover. And when we do shift change, we value everyone's opinion and everyone's interpretation of what has gone on during the day with the person that they have been overseeing. Basically, when they are speaking about those things that have been important to our individual that's been helped, we feel it's important that all of that is shared. Every team member is responsible for the creation and maintenance of the healing spaces and know force first. It's also important to realize we do have this multidisciplinary approach, a team effort, all sending a message of hope. Next, please. So let's talk about what the alternatives that are offered by the RRC. First of all, we offer an alternative to the emergency department use for psychiatric crisis events. Oftentimes, our psych patients are sitting in the ER and they are not being treated for their psychiatric illness, and they're waiting on that to happen, and they're waiting on a bed. So bringing them to the RRC really avoids all of that. We also act as an assessment center for petitions, and I'll describe that in a minute. And we offer a supportive environment that may assist individuals to avoid an inpatient hospitalization. We also use the best practice philosophy of no force first. So let me tell you what that means. That means that we use therapeutic options, which is evidence-based, and it is relational driven. And how we do that is that we try to de-escalate folks verbally. We utilize folks that they may have established a bond with on their team, and we move them to a quiet place so that they can de-escalate mostly on their own, but with some help. If that fails, basically we can bring them to a seclusion room, which we do very, very infrequently. And the only time that we ever have used restraints is when there was someone who was a danger to themselves or to others, and when the safety of the milieu was questioned. In that case, we will use restraints if we have to, but we pride ourselves on being no force first. The other thing that I would like to kind of talk with you about is our petitioning process in Arizona. The RRC acts as an assessment center for this, and a person has to demonstrate a danger to self, a danger to others, or being persistently gravely disabled. And this must be documented in an order in order to have the individual picked up by the police to be evaluated by a medical provider. The police bring in the individual. The med provider will review the document and do an assessment for approximately 3 days if needed to determine if this person needs any further treatment and if they are willing to take treatment at the time. Basically, that would entail going to court and being placed in a inpatient hospital at the time. And going to court means that if the judge agrees, then this person would be on court order for 365 days. What we do is we try to stabilize that individual after the assessment in our living room, and many times because of this, the treatment that they get and the time that they can spend, the petition is dropped. It's important for you to realize, too, that we do not deny service. What we do is we redirect it. Instead of going to the ED or into a hospital or even being petitioned, if we can, we will take care of that individual in our system. Next, please. So we have to develop community relationships, as I'm sure you all have to do in certain instances, and our community relationships are very important to us. We work with our external stakeholders and hold them as an important part of our recovery response center. We work closely with law enforcement to help them understand that they can bring anyone to us anytime, and we will serve that person. Every time we serve an individual who is brought in by the police, that individual is not being taken to jail. And we feel that that's a very important aspect in treating mental illness. We have developed work relationships with hospitals and clinical teams, mobile crisis teams, in order to help folks to get out of the ED so that they can go on to having treatment. We create a welcoming atmosphere for parents and for loved ones to visit, and we have very flexible hours for visiting. In doing this, we also give families resources along with linking their loved one to a provider and other community resources. In doing this, we work at giving the family hope as well. Next.
I think the visits are so important because they keep people connected to their life outside, to their families, and we really think that that's important because in settings when people come in, we don't want them to experience isolation in there by being disconnected to the people that are important in their lives. And so we don't want that when people are out of a treatment center, and we don't want people to have that experience in the treatment center.
And this is part of that social connectedness. If we have someone who is isolated in a hospital, let's say, oftentimes families have a difficult time getting in, finding out what's going on. And in our case, we really do value that family relationship or whatever support system that they have. And then once they are out in the community, they have maintained that support system and probably will be making other choices as far as support people. So it's very, very important. Okay. Thank you, Lisa. The RRC and its value. Well, we talked about diversion, and this is our Peoria site, by the way. We divert about 200 individuals each month from hospitals and EDs to our treatment center. And basically, that's a lower level of care, and yet we are taking care of them and using what we need to assist them. People are brought to the RRC by police, approximately 70% of them, and 30% are brought in by mobile crisis teams, family, or by self-referral. Our Peoria site also sees 5,000 unique individuals each year. And again, we should be very clear that we're not denying services. We are redirecting them to our treatment center and getting folks out of the hospital, not out of the hospital, or out of the ED, and perhaps decrease hospitalization, which is often very traumatic for individuals in crisis. So
and
I'm sorry, go ahead.
Sorry. And also, every time someone will come to the RRC, especially when they're brought by to the police, it's a time when they didn't go to jail instead.
Correct. From the lobby to linkages to community resources, treatment and service are available to all those who need it. Next, please. So besides having some value in what we just talked about, we have an even higher value, we think, in the average length of stay in comparison our retreat to the emergency department and living room to hospital. Our retreat, again, our length of stay is about 22 hours, and that is an observation unit. In the emergency department, it is variable, but research has showed that it is approximately 6.8 to 34 hours in the emergency room waiting on a bed and or being seen by a psychiatric professional. In the living room, we have a 2.4 length of stay, which can go up to 5 if it's needed. And in the hospital, the difference is 7 to 14 days. So you see that inpatient hospitalization becomes much longer, whereas in the living room, we are really ready to help that person and do it on an individual basis, as well as discharge them to community services, their team, whoever needs to be involved in their care. And you may say, well, it says here that the average for an emergency department is more than 12 hours. Well, the reason that we have high value is, and we can change to the next slide, is that in cost analysis, the RRC costs about 1/3 of an ED visit. So we feel that that is very important, and it's very important to have our EDs ready for those who have medical problems, and we need to be able to take care of our psychiatric patients who have problems. So in that 1/3, that's value added. We also, our return visits within the same month are only at 5%. And because we have peers who assist our folks, follow-up in ED visits has decreased within the first 30 days. And another reason why our peer supports are so important. Next. Okay. We also divert court petitions when it's necessary, when we can, basically. About 65 to 70% of petitions are dropped at the Peoria site. Thus, they are not sent to the hospital for court. They are not court-ordered for a year, and it gives them the ability to continue on in the community and to be able to be treated by their outpatient team. Dropping a petition and any other treatment recommendations are the result of the whole team input, but the medical provider does determine after assessment what should be done with that petition. Next. Outcomes. Now, outcomes, you hear this is the buzzword all over the place anymore. Everyone wants to pay for good outcomes and can't blame them for that. But what we have found in our other RRCs is a significant reduction in hospital and ED visits. Our RRC in Ellendale, Delaware, had a 50% reduction in ED use. It also had a hospitalization rate reduced from 48% to 10%. And in Fife, Washington, because of our peer supporters who watch, I wouldn't say watch over, but really do a great deal with individuals who are discharged, we have reduced hospitalizations by 79%, from 202 individuals per year to 40 individuals per year. Those are really terrific outcomes. So in summary, what do we know? We know that our system assists folks in crisis. They assist in helping families and individuals with mental illness work their way through the healthcare system, which is sometimes very cumbersome. We help with diverting from the ED to a crisis recovery center rather than sitting in the ED waiting for a bed to open or even for someone to see them. We also have found that it assists in decreasing hospitalizations, which can be very traumatic for folks, and it is the highest level of care, and we would rather not have to use that if possible. We also know that peer coaches assist those we treat, and this has decreased recidivism, ED visits, and unnecessary hospitalizations. So with that, I'm going to hand it over to Lisa so she can let you know all about our peer support coaches. Thank you.
Thanks a lot, Karen. Mm-hmm. Peer supporters are a great addition to any multidisciplinary team. They can provide, next slide, empathy and support and help people take back their power and understand that they have a part to play in their care. They use their journey as a tool for hope. In fact, we think that one of the most important roles, not just for peers, but for all people who serve individuals with mental health challenges, is to create a feeling of hope in them that things can change and get better. As people work as peer support specialists, their recovery also improves. Next slide. So it's important when we bring peers onto our multidisciplinary teams that they are trained well. And RI International has provided peer training for over 15 years. At any given time, about 2/3 of our staff are peer support workers in identified peer roles. They're really important members of our team. And with our training, we have trained over 7,000 peer support workers across the USA and abroad since the year 2000. Our training thoroughly covers SAMHSA's identified competencies for peer trainings and meets those competencies. Next slide. The training consists of 80 hours of class interaction over a 10-day period of time. We look at conflict resolution, trauma-informed care, communication, substance use, emotional intelligence. We help people to understand what we mean when we talk about recovery and what's possible for people. We also have documentation and partnering with the other people that you're going to be working with and how to do that well. It provides certification in multiple states and countries and is currently the Veterans Administration's preferred training option. And we have trained veterans for many years, but acquiring this particular opportunity to serve our veterans has been really an important part of our work. RI's Recovery Response Center has worked with peer support specialists since 2003. And we started with one peer support in the lobby greeting people. And now we have peers throughout that entire system in every location. Next slide. So we have a poll now, and you'll see it at the bottom of your screen. And we'd like you to fill that in if you would. And we see that lots of people are answering that they don't have any peer supporters in their crisis services. I see very few that think that people with lived experience can't handle the stress of crisis work, and that's great. Because our experience has told us that peers are very strong people. They've been through a lot in their life, and once they understand how to use that effectively, all that skill and knowledge they've gained through the years, they make really good workers.
And I think it's really important, Lisa, to let folks know that although they go through this peer training, they don't necessarily have to work for RI International or at the RRCs. They can get jobs wherever they would like to.
Yeah. And there are lots of peers in lots of states doing great work. So we also see that a proportion of you have fully integrated teams with many peers working alongside non-peers. So that's also great. And that lots of systems have peers available in support roles. I see one that says we have one or two peers working in the crisis service, and it's been our experience that we need a larger group of peers in all of our workplaces so that they can support the team in bigger ways and work with more people and be the example of recovery within your team, because through their participation, recovery will begin to happen for your team members. In other words, they'll begin to understand and believe in the possibility of recovery, not just for the peers on their team, but for everyone that they serve. And by recovery, I mean everybody can lead a full life in spite of the challenges that face them. They can learn how to work through those challenges.
Lisa, this is Lori. I'm interrupting just to let you know you have about 10 minutes if we want to leave any time for a lot of questions that we're getting for you guys.
So let's change to the next slide. So from the moment people are admitted, during every phase of their admittance, from the very beginning, they have a peer that is working with them. And it will change with shifts and whatnot, but there'll be peers around them all the time. Next slide. So when peers work with someone and they're making their plan to exit the Recovery Response Center, they can follow up with them in the community and go to all kinds of appointments with them that might be scary at first and offer support. They can go to people's homes. They can help them connect in the community, teach them how to ride the bus, all kinds of things. Help them get social services that are needed that they've probably gained a huge understanding of during their time that they might have needed to use those services. Next slide. So throughout our organization, peers do all kinds of services. They run our psychosocial rehab groups. They, in our recovery response centers, they check acuity levels and vital signs. All of our peers and all of our organization document inside the healthcare record. And our peers go right up from a starting position all the way up into the highest levels of leadership in our company. Next slide. We employ peer supports and work with them in the development of their employment skills. We want them to work with people and help them to see themselves as becoming employees. We want them to strengthen the involvement of their opportunities in the community. And what we see is that a lot of peers come into this work, and other people who want to go into the work are doing it because they want to give back. And they want that sense of belonging that comes from work. Next slide. So essentially, the peers support specialists become a reflection of recovery for the people that they're serving. I like to call them living, breathing hope. What we're learning is that, next slide, is that peer support has been a great value in our crisis response centers. They support people to learn and understand that self-management is possible, that they can increase their skills around their personal wellness. They offer support to individuals, either advocating for them or helping them to feel supported so they can advocate for themselves. They look at wellness activities when they go out and work with people in the community that might include a walk around the block, healthy eating habits, and all kinds of things. Karen mentioned that it reduces emergency department use and hospital use. Let's go to the next slide. So in workforce development, all the team members that we hire, regardless of their role, go through a new hire orientation, getting the foundational skills of the work that they're going to do. In addition to that, our peer team members have 80 hours of the peer employment training that we provide, and that training aligns with the core competencies. Let's go to the next slide. We have other tools that organizations and peer supporters can use once they've completed peer employment training, or if they're bringing peers onto their team, and they include supervising a peer workforce, keeping the recovery skills alive, which is a supervision tool where there are 52 modules that can support people in supervision throughout the year, one a week. And then there are some others that are listed there, and they're important because they're continuing education for peer specialists. We think that their education has to be continuous, and we're learning that peers need to grow in their work as peer supporters, not morphing into other roles through other trainings that don't focus on their role. Next slide. So we teach team members how to respond to people and with people who are highly distressed. People who have used the RRC are able to share their personal stories sometimes with our team. And sometimes people come back just to explain to the team that they've been served by how much better they're doing or how things are working for them. Every team member gets 1 hour of supervision for every 40 hours that they work, and we feel that that's important and helps them to stay connected to our focus on recovery. We value each team member and the unique aspects that they bring to the job. So if you want to, let's go to the next slide. Get started right now with your peers in your company so that their presence is felt by the rest of the team. Leadership will demonstrate that it values both peer support and recovery philosophy, and change the environment to reduce barriers. And we want to make sure that nurses' bubbles go away, that sitting behind desks doesn't happen so much, so that people feel like they're being connected with by individuals that are serving them when they're in that kind of a setting. And some of the other things you can do is use that, next slide, great language that is not focused on what's wrong, but is focused on hope and possibility. So we encourage words like, when you're better, once you're home, what are your plans? And we ask people continuously, what do you need? How can we help? And then we are ready to listen to them deeply and really stay in connection with them and believe in the possibility of recovery for each and every person. Thank you.
Lori, your mic is not on. Sorry.
Can you hear me now?
Yes,
missed
yes.
my whole wonderful intro to the question.
Oh, I'm so sorry we did.
My apology. I was just saying, for those of you who could not read my lips, that it was a delightful presentation, and you've stimulated a great deal of conversation, both in the chat and a number of questions have come in. We have a few minutes for questions, so let me focus on the one that seems to be the most common theme, at least initially. And I'm going to put this towards you to start, Dr. Cheney, and Lisa, you may want to chime in on this, and that's funding. People are very impressed with what you're doing. They want to know where it is all around the country. Do you have one in my area? That kind of thing. But how are these programs being funded?
Well, I'm sorry, my computer just went down here. Funding it's quite different, but usually in the places that we are funded by a managed care organization, which is covering all the mental health for certain counties or for the state, and that's how we are funded for the most part.
And what's interesting to know is that lots of our peers are in roles where they can bill Medicaid,
right.
And they either bill peer support if the state has that as something that's billable in Medicaid, or they bill psychosocial rehab codes.
So everyone is able to bill, and most of our folks are Medicaid, although not all of them.
So I'm drawing an extrapolation there to answer another question. All the peers on your workforce are paid workforce, or it's a paid workforce. It's not a volunteer workforce.
Correct.
Okay. Yeah.
Okay, that's very, very helpful. Another series of questions came in, and I'll let the two of you decide who can best field this. But that is talking about how are you working with individuals who have substance use disorders? How does that play into your services and how you work with that, particularly if it's a primary substance use issue? And also, kind of related to that, a little different, is people who have physical health problems. And, how are you connecting and helping people connect with services in the community around physical health problems? So these other populations would like to pick that up.
Lisa, do you want to answer the one on substance use?
Yeah. So a lot of the people that come to see us, great many of them have substance abuse as their primary reason for coming to us. So we are very used to working with people in their early detox process and supporting them until they're able to exit, or if they need further care, move into a higher level of care. But we've treated people in our recovery response centers for years that have substance use challenges. It's the two mental health and substance use go hand in hand.
Mm-hmm.
Yes. And often, to just piggyback on that, if they have, if they're going to be at risk for detox, we do utilize a hospitalization until their detox is over. We don't want to, we want to do the appropriate level of care if they are detoxing from alcohol use and that sort of thing.
And we care for people who have physical health challenges, of course.
Yes.
Mm-hmm.
But if we, in their assessment when they come in and the nurse is looking at them while the peer support is supporting, if they're having a health challenge that would put them at risk if they came in the RRC because they need higher levels of medical care, then we will ensure that they get what they need and send them to a nearby hospital.
Following up on that, would you expand a little bit on how you're coordinating with community services and some of that linkage area, both through peers but also through some of the professionals in your teams?
Let me start, and I'm going to let you finish it, Lisa. Many of the folks that come in, let's say to the Peoria RRC, are part of the seriously mentally ill population who are provided with medical providers and teams, case management, and that sort of thing. So oftentimes we will, well actually all the time, we coordinate with their team, let them know what's going on. We also collaborate on what needs to be done or what we think needs to be done. We do doc-to-docs, and all of that is just standard of care. Once they leave, and if they need additional community resources, we certainly make sure this happens, and we make sure that we let the team know what we see as being needed. We listen, and Lisa brought this up before. Part of the treatment plan, or all of the treatment plan, is based on what the needs of the individual is. And those needs that is in the treatment plan. And so we basically we share that with those folks in outpatient who take care of them on a regular basis. Lisa, anything to add?
Yeah. So if they've never been in the system and they're a person who might benefit from being in the public mental health system, then we can help them to know how to enter and get the right support to walk them through that. In addition, we are in constant contact with our community partners on where there are beds, what else needs to happen, how can we support this person, and we ensure that they have connections made before they leave the RRC, and we are there to help them follow up.
And at times, some folks come in and they have not been designated seriously mentally ill, and we help with the evaluation of this person and the assessment for that designation if it's needed.
There's a person who wrote a note down below, and I just want to mention it because it's an important question about language. When we have people come in who do not speak English, if we don't have a staff member that speaks their language, we have Language Line, and we access in every way we can to work with them in the language of their choice.
Going along with kind of the accommodations to lots of different people and different needs, people are acknowledging that you're doing some really phenomenal work with peer supporters in the crisis and crisis alternative arena. The question's going to come up as well about what are you doing, if anything, around family-to-family peer support? Because it's not just individuals coming in who are impacted by a mental health crisis, it's everyone around them, including family members. So could you talk a little bit about what your thoughts are or what's going on in your services in that arena?
Lisa, I'm going to give that one to you because you did well in that.
So we have 2 trainings that we've developed specifically for family members to help them learn how to work within systems themselves and to increase their understanding of recovery and to help them feel included in the whole process. In our recovery response centers, the parent can come to any meeting, the family member can come to any meeting with the individual and their team at the Recovery Response Center. And again, I want to mention that open visitation so that family members do not feel pushed to the side, and that they feel included as part of the process if the person says that that's okay, because the person is the one who's driving their care.
One other addition here is that in the outpatient system, many of the providers have family mentors. So they will assist with the families and with the individual in whatever way is necessary.
I may be opening a can of worms here at the very end of the webinar, but there's a fair amount of interest and appreciation for No Force First, and a lot of questions about how that really works on the ground in terms of actual use of restraint, the kinds of circumstances under which that might happen. You know, what does that really look like and feel like?
Can I take this to begin with? So in the beginning, when we started looking at changing our philosophy from, one that was very comfortable with restraint to one that was, going for zero restraint, before, if a participant knocked on the nurse's station window once or twice and then came back and did it again, they might be restrained. And there's sort of this, there was a sentinel kind of way of being that the staff had of watching people and monitoring their behavior. We started to shift that, and we soon realized that zero restraint is not really it can't really occur because sometimes we need to help people keep themselves safe, and we need to keep the environment and the other people that are being served by us safe. But it is the last thing that we go for, and we will try to help them feel calm. And even one of our leaders described a situation where a participant was very angry and started kind of throwing chairs around and stuff, and so everybody was, just asked to go to their rooms, and she stood with that person, and she moved the coffee and the tea away so that wouldn't be a danger. And she said, I understand because I've been there. And then immediately, coming from that peer support place, the person broke down crying, and they felt that kind of support coming from someone who understands.
Dr. Cheney, we've got about 29 seconds for you to add to that.
Well, it is a lofty goal to say no restraints and no seclusion. And as Lisa said, I don't think we can, that probably isn't real. But we train everyone in therapeutic options, and in the past it was CPI, so that they understand what can be done in order to assist these folks. And basically, therapeutic options always talks about verbal de-escalation and utilizing folks that are important to that person. So, we really work at not using seclusion or restraint, but if it has to be, we do.
Wonderful. Thank you so much, both of you, for this phenomenal and exceptionally rich webinar. I want to extend my personal thanks and the thanks of SAMHSA, as well as all the participants on the webinar today, for your comments and your forthright consideration of these issues. For further information, a lot of people have asked, how do we get in touch with you? Please see the email and the website information here on this slide. Feel free to contact Dr. Cheney and Lisa St. George. We also invite your comments at Recovery to Practice. One of the things, this is the last of our winter webinar series. We are in the process of planning our spring webinar series, and we are excited about that. So stay tuned for your in your email for excuse me, what that webinar series will look like and when it will be scheduled. We'll also be releasing the Spring Recovery to Practice newsletter in mid-March, and following that newsletter release, we will have a webinar to explore and deepen and enrich the content in that newsletter. This newsletter will be focused on readiness and recovery transformation in organizations. So we are actively putting that together right now, so keep an eye on your email from Recovery to Practice. In the meantime, please check the Recovery to Practice website for updates and archives. This webinar will be archived and uploaded to the Recovery to Practice website with the PowerPoint slides. Please provide your feedback on the slide that will come up as you begin to close off. However, if you are interested in receiving NADAC continuing education hours for this webinar, please click on this link here. You see NADAC CEH, and you'll be directed directly to a page that will give you the evaluation and a quiz and the certificate. If you're not interested in NADAC CEHs, you can download your certificate of participation here now. On the bottom of your screen, you'll see a materials download. So please take the time to complete the evaluation, and on behalf of SAMHSA, I would like to thank you very much for participating in today's webinar, and we look forward to seeing you in the spring. And this concludes today's webinar. Have a good afternoon.